Malignant hyperthermia or malignant hyperpyrexia is a rare life-threatening condition that is usually triggered by exposure to certain drugs used for general anesthesia, specifically the volatile anesthetic agents and the neuromuscular blocking agent, succinylcholine. In susceptible individuals, these drugs can induce a drastic and uncontrolled increase in skeletal muscle oxidative metabolism, which overwhelms the body's capacity to supply oxygen, remove carbon dioxide, and regulate body temperature, eventually leading to circulatory collapse and death if not treated quickly. Susceptibility to MH is often inherited as an autosomal dominant disorder, for which there are at least 6 genetic loci of interest, most prominently the ryanodine receptor gene. MH susceptibility is phenotypically and genetically related to central core disease, an autosomal dominant disorder characterized both by MH symptoms and myopathy. MH is usually revealed by anesthesia, or when a family member develops the symptoms. There is no simple, straightforward test to diagnose the condition. When MH develops during a procedure, treatment with dantrolene sodium is usually initiated. Dantrolene and the avoidance of inhaled anesthesia in susceptible people have markedly reduced the mortality from this condition. Classification: this condition is known by a number of names, including malignant hyperthermia, malignant hyperthermia syndrome, malignant hyperthermia susceptibility, and malignant hyperpyrexia. Signs and symptoms: the typical symptoms of malignant hyperthermia are due to a hypercatabolic state, which presents as a very high temperature, an increased heart rate and breathing rate, increased carbon dioxide production, increased oxygen consumption, acidosis, rigid muscles, and rhabdomyolyses. The symptoms usually develop within 1 hour after exposure to trigger substances, but may even occur several hours later in rare instances. Causes: malignant hyperthermia is a disorder that can be considered a gene-environment interaction. In most people with malignant hyperthermia susceptibility, they have few or no symptoms unless they are exposed to a triggering agent. The most common triggering agents are volatile anesthetic gases, such as halothane, sevoflurane, desflurane, isoflurane, influrane or the depolarizing muscle relaxant suamethonium and acamphonium used primarily in general anesthesia. Other drugs that have been suspected of causing MH include catecholamines, phenothiazines, and monoaminoxidase inhibitors. There are also few reports of MH being triggered by nitrous oxide administration. In rare cases, the biological stresses of physical exercise or heat may be the trigger. Other anesthetic drugs are considered safe. These include local anesthetics, opiates, ketamine, barbiturates, nitrous oxide, propofol, etomidate, benzodiazepines. The non-depolarizing muscle relaxants pancuronium, cisatracurium, atracurium, mivacurium, vicuronium and rocuronium also do not cause MH. There is mounting evidence that some individuals with malignant hyperthermia susceptibility may develop MH with exercise and/or on exposure to hot environments. Genetics: malignant hyperthermia's inheritance is autosomal dominant. The defect is typically located on the long arm of chromosome 19 involving the ryanodine receptor. More than 25 different mutations in this gene are linked with malignant hyperthermia. These mutations tend to cluster in one of 3 domains within the protein, designated MH1-3. MH1 and MH2 are located in the N-terminus of the protein, which interacts with L-type calcium channels and Ca2+. MH3 is located in the transmembrane-forming C-terminus. This region is important for allowing Ca2+ passage through the protein following opening. Chromosome 7q and chromosome 17 have also been implicated. It has also been postulated that MH and central core disease may be allelic and thus can be co-inherited. Pathophysiology, disease mechanism: in a large proportion of cases, the propensity for malignant hyperthermia is due to a mutation of the ryanodine receptor, located on the sarcoplasmic reticulum, the organelle within skeletal muscle cells that stores calcium. A wire1 opens in response to increases in intracellular Ca2+ level mediated by L-type calcium channels, thereby resulting in a drastic increase in intracellular calcium levels and muscle contraction. AYO1 has two sites believed to be important for reacting to changing Ca2+ concentrations, the A site and the I site. The A site is a high-affinity Ca2+ binding site that mediates AYO1 opening. The I site is a lower affinity site that mediates the protein's closing. Caffeine, halithan, and other triggering agents act by drastically increasing the affinity of the A site for Ca2+ and concomitantly decreasing the affinity of the I site in mutant proteins. Mg2+ also affect AYO1 activity, causing the protein to close by acting at either the A or I sites. In MH mutant proteins, the affinity for Mg2+ at either one of these sites is greatly reduced. The end result of these alterations is greatly increased Ca2+ release due to a lowered activation and heightened deactivation threshold. The process of sequestering this excess Ca2+ consumes large amounts of adenosine triphosphate, the main cellular energy carrier, and generates the excessive heat that is the hallmark of the disease. The muscle cell is damaged by the depletion of ATP and possibly the high temperatures, and cellular constituents leak into the circulation, including potassium, myoglobin, creatine, phosphate and creatine kinase. The other known causative gene for MH is CACNA1S, which encodes an L-type voltage-gated calcium channel I+- subunit. There are two known mutations in this protein, both affecting the same residue, R1086. This residue is located in the large intracellular loop connecting domains 3 and 4, a domain possibly involved in negatively regulating AYO1 activity. When these mutant channels are expressed in human embryonic kidney cells, the resulting channels are 5 times more sensitive to activation by caffeine and activate at 5 euro 10 MV more hyperpolarized. Furthermore, cells expressing these channels have an increased basal cytosolic Ca2+ concentration. As these channels interact with and activate AYO1, these alterations result in a drastic increase of intracellular Ca2+, and, thereby, muscle excitability. Other mutations causing MH have been identified, although in most cases the relevant gene remains to be identified. Animal model research into malignant hyperthermia was limited until the discovery of porcine stress syndrome in Danish landrace and other pig breeds selected for muscling, a condition in which stress pigs develop pale, soft, exudative flesh rendering their meat less marketable at slaughter. This awake triggering was not observed in humans, and initially cast doubts on the value of the animal model, but subsequently, susceptible humans were discovered to awake trigger in stressful situations. This supported the use of the pig model for research. Pig farmers use halithan cones in swine yards to expose piglets to halithan. Those that die were MH susceptible, thus saving the farmer at the expense of raising a pig whose meat he would not be able to market. This also reduced the use of breeding stock carrying the genes for PSS. The condition in swine is also due to a defect in ryanodine receptors. Gillard et al. Discovered the causative mutation in humans only after similar mutations had first been described in pigs. Horses also suffer from malignant hyperthermia. A causative mutated allele, ryanodine receptor 1 gene at nucleotide C7360G, generating a 2454G amino acid substitution, has been identified in the American quarter horse and breeds with quarter horse ancestry. Inherited as an autosomal dominant, it can be caused by overwork, anesthesia, or stress. In dogs, its inheritance is autosomal recessive. An MH mouse has been constructed, bearing the O163C mutation prevalent in humans. These mice display symptoms similar to human MH patients, including sensitivity to halithan. Blockade of RYO1 by dantrolene prevents adverse reaction to halithan in these mice, as with humans. Muscle from these mice also shows increased K+- induced depolarization and an increased caffeine sensitivity. Diagnosis: during an attack, the earliest signs are early masseter muscle contracture following administration of succinylcholine, a rise in end-tidal carbon dioxide concentration, unexplained tachycardia, and muscle rigidity. Despite the name, elevation of body temperature is often a late sign. Other signs may include acidosis, tachypnea, cyanosis, hypertension, cardiac arrhythmias and hyperkalemia. Core body temperatures should be measured in any patient undergoing general anesthesia longer than 20 minutes. Malignant hyperthermia is diagnosed on clinical grounds, but various investigations are generally performed. This includes blood tests, which may show a raised creatine kinase level, elevated potassium, increased phosphate and if determined raised myoglobin. This is the result of damage to muscle cells. Metabolic acidosis and respiratory acidosis may both occur. Severe rhabdomyolysis may lead to acute renal failure, so kidney function is generally measured on a frequent basis. Patients may also get cardiac arrhythmias due to the increased levels of potassium released from the muscles during episodes. Susceptibility testing. In those who have experienced an episode of MH, further testing is not usually useful, as even a normal test does not mean there is no risk of recurrence. The exception would be if it is unclear whether the initial attack was due to a different medical problem, such as sepsis. Muscle testing. The main candidates for testing are those with a close relative who has suffered an episode of MH or has been shown to be susceptible. The standard procedure is the caffeine halathan contracture test, CHCT. A muscle biopsy is carried out at an approved research center, under local anesthesia. The fresh biopsy is bathed in solutions containing caffeine or halathan and observed for contraction. Under good conditions, the sensitivity is 97% and the specificity 78%. Negative biopsies are not definitive, so any patient who is suspected of MH by their medical history or that of blood relatives is generally treated with non-triggering anesthetics, even if the biopsy was negative. Some researchers advocate the use of the calcium-induced calcium release test in addition to the CHCT to make the test more specific. Less invasive diagnostic techniques have been proposed. Intramuscular injection of halathan 6% has been shown to result in higher than normal increases in local peak O2 among patients with known malignant hyperthermia susceptibility. The sensitivity was 100% and specificity was 75%. For patients at similar risk to those in this study, this leads to a positive predictive value of 80% and negative predictive value of 100%. This method may provide a suitable alternative to more invasive techniques. A 2002 study examined another possible metabolic test. In this test, intramuscular injection of caffeine was followed by local measurement of the peak O2. Those with known MH susceptibility had a significantly higher peak O2. The authors propose larger studies to assess the test's suitability for determining MH risk. Genetic testing. Genetic testing is being performed in a limited fashion to determine susceptibility to MH. In people with a family history of MH, analysis for AYR1 mutations may be useful. Criteria. A 1994 consensus conference led to the formulation of a set of diagnostic criteria. The higher the score, the more likely a reaction constituted MH, respiratory acidosis, end tidal CO2 above 55 mHg/7.32 kPa or arterial peak O2 above 60 mHg/7.98 kPa, heart involvement, metabolic acidosis, muscle rigidity, muscle breakdown, temperature increase, other, family history, prevention. In the past, the prophylactic use of dantrolene was recommended for MH-susceptible patients undergoing general anesthesia. However, multiple retrospective studies have demonstrated the safety of trigger-free general anesthesia in these patients in the absence of prophylactic dantrolene administration. The largest of these studies looked at the charts of 2214 patients who underwent general or regional anesthesia for an elective muscle biopsy. About half of the patients were muscle biopsy positive for MH. Only 5 of these patients exhibited symptoms consistent with MH, 4 of which were treated successfully with parenteral dantrolene, and the remaining 1 recovered with only symptomatic therapy. After weighing its questionable benefits against its possible adverse effects, Experts no longer recommend the use of prophylactic dantrolene prior to trigger-free general anesthesia in MH-susceptible patients. Anesthesia for known MH-susceptible patients requires avoidance of triggering agents. All other drugs are safe, as are regional anesthetic techniques. Where general anesthesia is planned, it can be provided safely by removing vaporizers from the anesthetic machine, placing a new breathing circuit on the machine, flushing the machine and ventilator with 100% oxygen at maximal gas flows for 20–30 minutes, and inducing and maintaining anesthesia with non-triggering agents. Modern anesthetic machines have more rubber and plastic components which provide a reservoir for volatile anesthetics, and should be flushed for 60 minutes. Treatment. The current treatment of choice is the intravenous administration of dantrolene, the only known antidote, discontinuation of triggering agents, and supportive therapy directed at correcting hyperthermia, acidosis, and organ dysfunction. Treatment must be instituted rapidly on clinical suspicion of the onset of malignant hyperthermia. Dantrolene is a muscle relaxant that appears to work directly on the ryanodine receptor to prevent the release of calcium. After the widespread introduction of treatment with dantrolene, the mortality of malignant hyperthermia fell from 80% in the 1960s to less than 10%. Dantrolene remains the only drug known to be effective in the treatment of MH. Its clinical use has been limited by its low water solubility, leading to requirements of large fluid volumes, which may complicate clinical management. Azumaline is a 30-fold more water-soluble analog of dantrolene that also works to decrease the release of intracellular calcium by its action on the ryanodine receptor. In MH-susceptible swine, azumaline was as potent as dantrolene. It has yet to be studied in vivo in humans, but may present a suitable alternative to dantrolene in the treatment of MH. Research in mouse models suggests that azumaline is likely uncoupling the efficiency of a Ca2 ± dependent AYA1 signal coupled directly or indirectly to the store-operated calcium entry machinery. There may be two different pathways of store-operated calcium entry, one, AYA1 reliant and the other, AYA1 non-reliant. Furthermore, elucidating earlier ideas on the pathogenesis of malignant hyperthermia, researchers point out that it may be as much a syndrome of exaggerated Ca2+ entry as it is of exaggerated Ca2+ release. Azumaline has also been shown to be as effective as dantrolene at preventing and reversing contracture in vitro experiments with human skeletal muscle. Prognosis is poor if this condition is not aggressively treated. In the 1970s, mortality was greater than 80%. With the current management, however, mortality is now less than 5%. Epidemiology, the incidence is between 1,5,000 to 1,50,000 a year 100,000 procedures involving general anesthesia. This disorder occurs worldwide and affects all racial groups. Most cases, however, occur in children and young adults, which might be related to the fact many older people will have already had surgeries and thus would know about and be able to avoid this condition. History: the syndrome was first recognised in Royal Melbourne Hospital, Australia in an affected family by Denborough et al. In 1962. Denborough did much of his subsequent work on the condition at the Royal Canberra Hospital. Similar reactions were found in pigs. The efficacy of dantrolene as a treatment was discovered by South African anesthesiologist Gaisford Harrison and reported in a 1975 article published in the British Journal of Anaesthesia. After further animal studies corroborated the possible benefit from dantrolene, a 1982 study confirmed its usefulness in humans. In other animals including certain pig breeds, dogs, and horses are susceptible to malignant hyperthermia. In dogs its inheritance is autosomal recessive. References. External links, Gene Review UW entry on malignant hyperthermia susceptibility, Malignant Hyperthermia Association of the United States, Making Anesthesia Safer, Unraveling the Malignant Hyperthermia Puzzle by Marilyn Green Larac, FASEB Breakthroughs in Bioscience.